and clinical practice guidelines, and also a Michigan man, which I love, Samir Gupta.
Thank you, Dr. Lay, for that really kind introduction. It's really a pleasure to be here to talk about my favorite topic, which is colorectal cancer screening, and also to share the podium with Dr. Folame, a close friend, and who definitely could be giving this talk as well. So these are my disclosures. I'd like to set the stage with a case, someone you all might be seeing in your practice every day, every week, a 48-year-old man who presents to established care. Their prior medical history is hypertension and obesity. There's no family history of colon or rectal cancer. The prior primary care physician had referred him at age 46 for colorectal cancer screening with colonoscopy, which he did not complete. And the quote here might be, "I try to do what my doctors tell me, but I've been busy with work and my young kids, and I heard I did not have to start until age 50. So some of the key questions here are, what is his risk for colorectal cancer, and how is it impacted by the changing epidemiology of colon cancer? And what is the evidence base to support screening, and which test is best for this patient?" So we'll review the changing epidemiology of colorectal cancer and then try and dig deep into some issues surrounding screening, including the impact of various screening strategies on incidence and mortality, some considerations for choosing a strategy, some of the evidence and recommendations about the age to initiate screening, and we'll review the 2021 U.S. Preventive Services Task Force guidelines. And then I'll just close by reviewing a couple of what I think are the two biggest challenges regarding colon cancer screening, which are regarding completion and abnormal test follow-up. So it's no news to this audience that colon cancer is a major public health problem. It's the third most incident cancer among men and women, and the second leading cause of overall cancer death, with about 150,000 cases annually and about 50,000 deaths annually. The lifetime risk is about 4 to 4.5% for both men and women. And if we look at the age distribution of colorectal cancer cases, currently about 13% of all cases are being diagnosed in people under age 50, 31% among people age 50 to 64, and people above age 65 still represent the majority of cases at 56%. One of the big challenges with colorectal cancer is it remains a disease that has significant disparities. And we have seen consistently that the incidence and mortality vary by race and ethnicity. And what this bar chart shows you are data for colon cancer incidence on the left and mortality on the right, broken down by racial ethnic groups. And the main point of this slide is that American Indian, Alaska Native individuals, shown in the purple bars, and non-Hispanic Black individuals, shown in the blue bars, have the highest colorectal cancer incidence and mortality compared to other groups. And the inset makes another point. So this is the data for American Indians separated from Alaska Natives. And what it shows in the dark purple bars is that Alaska Native individuals have the highest colorectal cancer incidence and mortality by a lot of any racial ethnic group in the United States. The good news story about colorectal cancer has been that for all ages combined, incidence and mortality have been improving over time. You can see the top bar shows the incidence data in blue and the bottom mortality data in yellow. And we've seen steady declines, but you get this hint of maybe something happening in terms of a leveling off. And we're going to talk about this. And there are a couple concerning trends that are going on that this graph doesn't tell the whole story about. The first is something that has been surprising to me, which is that the proportion of cases that are advanced stage at diagnosis has been increasing over time. So what these data show is the percentage of colorectal cancer cases that are local in the black line, regional in the red, distant in the blue, and unstaged in the pink. And you can see there that the regional and the local lines have crossed to the point where the proportion of regional stage disease is higher than local. And you can also see in the blue bar that distant stage disease is increasing. Another major problem that's been talked about a lot is that early age onset colorectal cancer is rising. This is now the third leading cause of cancer death under age 50. And we think this is due to a birth cohort effect, where people born 1950, 1960 or later have been having an increased colorectal cancer risk. And the driving factors behind this are not well established. What the graph on the right shows is that the biggest proportion of the increase, shown in the orange, has been in rectal cancer cases over time. So this is for 20 to 49-year-olds. And the next biggest increase has been in distal colon cancer, which is shown in the green lines, with a more small increase in proximal cancer. And we're now at the point where 45 is the new 50. The current colorectal cancer incidence among people age 45 is similar to what it used to be among 50-year-olds 20 years ago. It can also be said that 50 is the new 55. The absolute number and rate of rectal and distal cancer for people age 50 to 59 is rising. So there's some sample data shown in the graph. The dark green bar at the bottom shows increasing incidence for 45 to 49-year-olds, which we just talked about. And what's newer is what we're seeing in the 50 to 54-year-old group, shown in the middle green bar, where they have had increasing incidence to the point where their incidence is now similar or the same as what it is among 50 to 59-year-olds. And what this is telling us is that the factors, the birth cohort factors that have been driving early onset colorectal cancer are also likely driving later onset colorectal cancer. And this has really significant public health implications because this group that's 50 to 60 years old is less likely to be screened up to date, and yet now they're experiencing significantly higher risk for colon cancer than they used to. So the potential causes of this changing epidemiology for both earlier and later onset colon cancer should be examined through the lens of a birth cohort effect. And when we think about causes of a birth cohort effect, we have to think about the whole continuum from conception through adulthood and the various exposures that may be going on. So there could be things that are perinatal exposures, things that we're being exposed to in childhood, adolescent, and adulthood that are all contributing to the colon cancer risk. So literally there could be something in the water that is affecting us at all of these stages. In terms of what has been shown for causes or linked with the changing epidemiology, these may include the usual suspects that have already been linked to colorectal cancer, as well as some unique exposures. So these are data showing associations for early onset colon cancer. You can see here the familiar risk factors of obesity, alcohol, and smoking being associated with increased risk. What is more new here are data showing that consumption of sugar-sweetened beverages, including in adolescents, as well as in utero exposures such as long-acting sulfonamide antibiotics, maternal obesity, and the drug we used to use for nausea, bendectin, have all been linked with increased odds of early onset colon cancer. So these trends have major implications for clinical practice, and some of this has to be us working in partnership with our primary care clinicians to make sure that they know about these. So for people under age 45, we have two things that we can work on. One is that we need to make sure that we measure and act on family history of colon cancer. So at least one study has shown that among those with a family history of colon cancer and a diagnosis of colon cancer under age 50, if our practice guidelines for early colonoscopy had been followed for people who have a first-degree relative, about 82% of the individuals in the study could have had their cancers diagnosed earlier, and about 67% might have even had their colon cancers prevented if those practice guidelines had been found. The other point for people under age 45 is that we need to make sure that we're closing the clinical loop on potential red flag signs and symptoms of colon cancer. So this is not to say that every patient with rectal bleeding, iron deficiency, abdominal pain, melena, or a change in bowel habits needs to immediately have a colonoscopy, but that we need to triage these patients really carefully and make sure that we close the clinical loop, for example, within 30 or 60 days, to make sure the original working diagnosis was correct and that the symptoms have resolved. And if they haven't, that that patient be offered an opportunity to have a colonoscopy to rule out colon cancer. In terms of people age 45 and older, I think we have increased urgency to get people up to date, because the people who are not up to date are at even higher risk for colon cancer than they used to be. I'd like to switch gears here and talk about colorectal cancer screening. So this chart, which Dr. May was so kind to provide me with, shows the currently available U.S. Preventive Services Task Force recommended options for average risk screening. So we've got non-invasive tests such as the high sensitivity guaiac fecal occult blood test, the fecal immunochemical test, the stool DNA fit test, and then other techniques such as CT colonography, flexible sigmoidoscopy, and colonoscopy, which is the most commonly done test. So I want to see how many people we've got awake here today in the audience, and I just have an audience straw poll. So which of the following strategies have been shown by randomized trials to reduce incidence and colorectal cancer mortality? And maybe just by a show of hands, how many think guaiac fecal occult blood testing? How many say FIT testing, FIT DNA, a CT colonography, a sigmoidoscopy, and then a colonoscopy? Okay, all right, so lots of variation. And let's dig into this. Now, this issue has been in the news a lot. I think all of you may have seen this press that came out last fall. This included a quote that said, "Now, a landmark study suggests the benefits of colonoscopies for cancer screening may be overestimated." So let's dig into this. This was really in reaction to this study that was published in the New England Journal, the Nordic European Initiative on Colon Cancer Trial. This was done in Norway, Sweden, and Poland between 2009 and 2014. In this time period, there was no usual care population colon cancer screening going on. It was a randomized controlled trial among nearly 85,000 individuals aged 55 to 64 years old. And what they compared was a strategy of inviting people to colonoscopy. So there were 28,000 in this group versus no invitation, and there were 56,000 people in this group. They presented an interim analysis through up to 10 years of follow-up. The primary outcomes were incident and fatal colorectal cancer, and they did an intent to screen analysis. And as you look at these data, just keep in mind that the screening participation rate was 42% among people who were offered the colonoscopy who actually did it. So these were the primary or top line results. The graph on the left shows the data on incidence over time. The red line shows the colonoscopy invited group. The blue line shows the non-invited group. And you can see that just after year 6, there seems to be a separation where the invited group starts to have a lower colon cancer incidence. The right graph shows the data for mortality, and you can see over time the lines don't really separate. And this translated into a colon cancer incidence ratio of 0.82 and a mortality risk ratio of 0.9, and that 0.9 was not statistically significant versus the incidence was. Now we can dig a little bit more. I mentioned to you that only 42% of people who were invited to colonoscopy did it, and look at the per protocol analyses. And here's where we see what we might have expected from the study. Again, on the left shows the incidence curve, a nice separation occurring after about year 6 of follow-up. And on the right, you see the mortality curves where it appears that the mortality curves start to separate with a lower rate in the screening group after about year 6 or 7. This translated into a per protocol approximate 30% relative risk reduction in colon cancer incidence and approximate 50% relative reduction in colon cancer mortality, again on the per protocol analysis. So how do we explain the disappointing top line results of this study? So one is there could have been some bias in the study. One thing that was weird was that there was not a stage shift to earlier colorectal cancer seen in the screen group. And this was especially true in the patients who were enrolled in Poland. And so the question here was, did they end up getting a lot of worried, unwell people who might have had some symptoms of colorectal cancer who were especially enthusiastic about doing uptake of the colonoscopy? There also could be concerns about validity. So how much does their result really apply to our populations? They had a low rate of colonoscopy participation. The follow-up time wasn't quite long enough maybe to see mortality differences. And then there were questions raised about endoscopist performance. So nearly 30% of the colonoscopists in this study had an adenoma detection rate below the benchmark of 25%. So we could say that maybe these weren't optimal quality colonoscopies, but we well recognize we have colonoscopy quality issues in the United States as well. So in terms of conclusions from the Nordic study, the authors submitted that the benefit of colonoscopy may be more limited than previously hypothesized. I might say that the effectiveness of colonoscopy is highly dependent on participation quality and the time to realize the benefit. And I would add to this an additional counterpoint that there's increasing evidence from observational studies that colonoscopy exposure is highly protective from incident colon cancer. So studies from the US and Poland demonstrate persistent and substantially lower risk for colon cancer incidence and mortality, including up to 12 to 17 years of follow-up. And what's been estimated is an 80 to 85% relative reduction in colon cancer incidence and mortality, at least in these observational studies. So let's switch gears and talk a little bit about comparisons of strategies. And let's first look at the data on incidence and mortality randomized controlled trial evidence. And this is based on intent to screen data. So we have really good data that exposure to guaiac fecal occult blood testing can reduce incidence and mortality by about 20% relative to no screening. Sigmoidoscopy, we probably have the best data on, over 200,000 people randomized, about a 22% relative reduction in incidence and 28% relative reduction in mortality. And then I just showed you the Nordic trial results, which showed about an 18% relative reduction in incidence. And you can see here, we're start to scratch our heads, how could it be possible that colonoscopy would have a lower incidence reduction than sigmoidoscopy? And this, of course, has to do with differences in how the studies are done, what time period, and so on. So how do we select a test today? There are very limited head-to-head incidence and mortality data comparing one strategy to another. We'll talk about one of the abstracts from DDW that addresses this. So for now, we're left to base our choice on the sensitivity and specificity, observational data on incidence and mortality, the acceptability of these tests, and then modeling studies. And for the issue of sensitivity, specificity, and evidence on risk reduction, we've gone over the randomized controlled trial evidence for guaiac fecal occult, sigmoidoscopy, and colonoscopy. I can add to this that observational studies suggest substantial risk reduction for colon cancer incidence and mortality associated with exposure to colonoscopy and FIT. And then for the three most commonly done tests, we definitely see differences in the relative sensitivity and specificity. So for advanced neoplasia, colonoscopy, FIT, and FIT DNA, 95%, 25%, and 47%. In terms of sensitivity for colon cancer, it's 95% for colonoscopy, about 75% for FIT, and 93% for the FIT DNA. And then specificity for FIT, it's about 95%, and for FIT DNA, it's about 89 to 90%. Acceptability, so it's clear that participation varies substantially by the test offered. So these are data from two different randomized trials. The one on the left was one done at San Francisco General Hospital, which showed that patients who were offered a guaiac fecal occult blood versus a choice of doing the FOBT versus colonoscopy had substantially higher screening completion than those who were only offered a colonoscopy. On the right is a study that we did in Dallas, which showed that offering patients FIT outreach with a FIT kit achieved the highest screening participation relative to offering a patient a free colonoscopy versus usual care offers for screening. Modeling has been the way that the Preventive Services Task Force has the approach this Preventive Services Task Force has taken to try to sort out which of these strategies might be best. So they review the epidemiology and evidence surrounding screening. They use 3 models simulating over 100 strategies for screening, in which they vary the test type, the frequency, the age to start and stop. And it's important to keep in mind that they assume perfect adherence to participation and follow-up. So if you're offered a FIT, you do it every year, and if it's abnormal, they do colonoscopy. And if you're offered a colonoscopy, that 100% of people offered a colonoscopy do it. The outcomes they generally look at include colon cancer cases and deaths averted, as well as screening-related complications. And they really had 2 key questions. How do the test strategies compare? And what's the incremental benefit of initiation at age 45 instead of 50? And I'll focus on the first of these questions. So these are the modeling results, and here I focused on the 3 most commonly done tests. So FIT every year, the Cologuard every 3 years, or colonoscopy every 10 years. The dark blue bars show the number of colon cancer cases prevented per 1,000 persons screened over a lifetime starting at age 45. And the green bars show the number of deaths averted per 1,000 persons screened. And what you can see here is that for cases prevented, maybe a higher estimate for colonoscopy compared to FIT and Cologuard, but for deaths prevented, there's very little difference. And again, I'll just emphasize that this assumes perfect participation in these tests, and the Preventive Services Task Force used these data to conclude that the number of cases prevented and deaths prevented was pretty similar across the different strategies that they looked at. So here were their final recommendations. For people age 50 to 75, they continued to give screening a grade A recommendation. For people age 45 to 49, they had a new recommendation. So this was based on their modeling, plus the epidemiologic evidence showing increasing colon cancer risk. And this was a grade B recommendation, meaning that they had moderate certainty, a moderate net benefit. And then for people age 76 to 85, they gave screening a grade C recommendation, basically the recommendation to selectively offer screening because the net benefit may be small in this age group, especially if they're previously up to date with screening. In terms of modalities, they continue to recommend a menu of options, including FOBT annually, FIT annually, the Cologuard every 1 to 3 years, colonoscopy every 10, CT colon every 5, and a flex sig every 5 or every 10 with a FIT. And I'll just point out that age 45 is now widely endorsed by the American Cancer Society, AGA, ASG, ACG. The family medicine group has not yet endorsed it. And it's been shown consistently that screening is cost effective, including at age 45. It appears that FIT is cost savings and colonoscopy remains efficient. So on the horizon to think about screening, there are multiple trials of additional non-invasive tests that are set to report. There are 2 large studies of novel stool-based markers, including a Cologuard 2.0, as well as a new FIT RNA test that are going to be reported out. There are also 2 new blood-based markers that have completed enrollment in their studies, and we'll go over the results of one of these studies in just a little bit. I think we need to be prepared to consider 2 scenarios. We might have a stool-based test with performance better than the current FIT DNA. So imagine 95% sensitivity for colon cancer, 75% for advanced adenoma at a specificity of 90%. We also need to imagine a blood-based test with performance for colon cancer detection similar or better than FIT. So the impacts here could be that we have an opportunity to get the 30 to 40% of the population who's not up to date screened, so that's exciting. There will be more patients with abnormal tests requiring timely colonoscopy, and there could be a chance that some patients and primary providers may increasingly choose non-invasive options for screening over colonoscopy, and I hope we'll have a chance to talk about the implications of this more. So in summary for screening, I hope I've shown you that screening reduces incidence and mortality. There are multiple promising approaches to screening. The key evidence gap is comparative effectiveness of modalities, including the incremental benefit of endoscopic screening with colonoscopy. And in the meantime, I think we can still hold true to the mantra, that the best test is the one that gets done and done well. I'd like to close with a couple challenges, including screening participation and follow-up. These are data from the National Health Interview Survey that show the screening participation rate in the population, and they show that uptake is suboptimal and it really varies across the population. You can see that the red bar shows that the overall screening rate is 59%, and we have substantially lower screening rates for people who are age 45 to 49. So those are in these top brown bars, that we've got disparities by race and ethnicity with substantially lower screening rates among Asians, American Indian and Alaska Native individuals, and Hispanic individuals. We have gradients by education as well as by income. And then we continue to have disparities by insurance, with lower screening rates for those on Medicaid or public insurance, and of course, the uninsured having the lowest screening rates. We also know that follow-up of abnormal tests is suboptimal. So the completion rates vary from 18 to 69% nationally, and we've done a survey of Southern California health centers, federally qualified centers, and it ranges 18 to 57% at local community clinics. Our goal is 80%, and it's important to keep in mind that lack of completion is associated with a 2.5-fold increased risk for colon cancer death. And this is because 1 in 20 people with an abnormal FIT have colon cancer, and about 1 in 4 have a large polyp. And I still think there are a lot of primary care docs who don't understand these data and know the implications of having an abnormal FIT. So what are our opportunities for addressing screening rates? So we've got multiple evidence-based population-level interventions for promoting screening and follow-up. To me, the two that stand out are offering test choice, so making sure that when we're having conversations about screening, that we offer colonoscopy and at least one non-invasive test option, such as FIT or stool DNA FIT, and then mailed FIT outreach. So mailed FIT invitation, including a FIT kit with reminders, has been associated with a 22% absolute increase in screening participation over time. This is one of the best interventions to get a population-level screening up. For abnormal FIT follow-up, we have less rigorous evidence, but the evidence is growing. At the patient level, it looks like navigation benefits our patients. At the provider level, we need to have reminders and performance feedback on how people are doing with following up their abnormal test patients. And then at the system level, we need more automated referrals to colonoscopy, pre-colonoscopy calls, and patient registries to make sure that we're tracking these patients with abnormal tests. So we can return now back to our case, our 48-year-old man who's at average risk, who had been recommended previously a colonoscopy and did not complete one. My approach here would be to explain that colon cancer incidence is rising and that screening can reduce incidence and mortality, and that this is one of the reasons why we're recommending initiation of screening before age 50. I would offer a choice of strategies based on the patient preferences that take into account the test sensitivity, the specificity, and the effectiveness, as well as the convenience and acceptability, and then put in place some systems to promote completion and follow-up. So these are my take-home points. I've shown you that colon cancer remains a major public health problem, and that the changing epidemiology is resulting in 45 being the new 50 and 50 being the new 55. And we expect these increases in colon cancer incidence among older individuals to continue. I've also shown you that screening reduces incidence and mortality, and that we have major national and local opportunities to improve screening and follow-up. Thank you so much for your attention, and I'll look forward to your questions at the end of